Nej, du kan udgøre.
Hello, everybody. Welcome to this session 5A, Social Inequalities in Sickness Absence. My name is Claus Winter Nielsen. I'm a specialist in clinical social medicine from Denmark Central Region and University of Aarhus. And my co-chair.
My name is Ulrik Steen. Me too is specialist in social medicine. Also come from Central Region Denmark and Aarhus University. Very welcome.
Yes, and we have 6 presentations, but I think the organization committee have done some mistakes because Eleanor Middendorfer-Ruth have made her presentation earlier today. So we have only 5 presentations, and we will start now with Kjetil van der Wel, who will make a presentation about the association between welfare region and health-related unemployment. Please.
Thank you very much. It's a bit funny, of course, to be the first presenter in the sickness absence strand and not really looking at sickness absence, because this is sickness defined as non-employment among those who report an illness. But I will explain more about that shortly. Okay. Thank you. Yes, so this paper has been co-authored by my colleague Espen Dahl and also by Karsten Thielen from Copenhagen University. And actually it's a follow-up paper of a previous paper that we did when we looked at more specific welfare state indicators like generosity and active labor market policies. And so in this paper we wanted to look if we could find the same thing using a welfare state regime approach. So the motivation for this paper then has been twofold, because first, previous comparative studies and also welfare state studies into health inequalities have predominantly been looking at 2 out of 3 aspects of the sociological health concept, namely mortality measures and also self-rated health measures reflecting the illness dimension, like subjective health, and objective health, the disease dimension of the sociological health concept. So in this paper we wanted to relate to the third aspect of health, namely sickness. And sickness in the literature has been defined as the inability of an ill person to fulfill role obligations normally expected in society, and is thus exempted from those obligations and receives welfare from family or from the state. And this aspect of health need not act in the same way in its relation to welfare arrangements as does illness and disease. So, because sickness is a fundamentally social phenomenon, it's likely to be affected by the social structure, like labor market conditions, social norms and cultural diversity, and of course also welfare arrangements. So in our study we exploit the cross-national variation in the degree to which ill health translates into sickness in different societies, and assess the extent that this variation can be attributed to the welfare state arrangements in those countries. And a second motivation has been to empirically test two prevailing hypotheses from labor market research and comparative welfare state research on the relationship between welfare states, health, and employment. So there are two contrasting hypotheses, and one view is claimed by welfare skeptics that holds that generous and universal welfare reduces labor market participation in general, and especially among those groups who have limited gains and the highest strains in the labor market. And the reason, according to the welfare skeptics, is that low economic incentives to work will make a large proportion of the population prefer welfare. And this process is expected to gain strength over time through normative decay and increasing illegitimate benefit use. So from this perspective then, we should expect higher overall levels of sickness and also larger sickness inequalities in a welfare state like the Scandinavian, because it's known that they have more universally available and higher social benefits. And there's another perspective called either the social investment perspective or welfare resources perspective, and this perspective believes the relationship to be rather the opposite, that generous and universal welfare increases rather than reduces labor market participation. And the explanation for this is that it is believed that important collective resources are made available to broad sections of society, and especially to disadvantaged groups. And these resources enable and stimulate social participation and also labor market participation. So, for example, if you're depending on a generous sickness benefit during health-related absence from work, it may prevent further downward social mobility and economic stress and material shortage, and hence it may prevent deteriorating health. And another mechanism would be that generous out-of-work benefits may be considered a resource for better job match among people with an illness, which in turn facilitate more stable employment. So if people have the possibility to take their time, they're not pushed into a job that doesn't fit them, they are more likely to find a job that is actually can be compared with the illness that I have. Okay, so the data we use are collected by EU Silk in 2005, or at least organized by Eurostat and EU Silk. And our sample consists of 200,000 men and women aged 25 to 59 years, living in 26 different countries. And our dependent variable then is non-employment, defined as all those who are not students and not working and not in military services. And our health measure was limiting long-standing illness. And we use education as a measure of social position, and it was divided into primary, secondary, and tertiary education. And of course, on the country level, we use welfare regimes, and we identified in the literature 5 different regimes, although it may be disputable. Some of them, it's the Anglo-Saxon and the Bismarckian, in the Eastern, the Scandinavian, and the Southern. And also we included country-level indicators of GDP and a measure of business cycle, so to properly account for labor market and economic conditions in each country. And we fitted our analysis using multi-level logistic regression models, including some individual level variables and some contextual control variables, that's the country level. And then the effect of welfare regimes was divided into 3 components. So there's a main effect for each regime, using the Scandinavian regime as reference category. And then we added cross-level interaction terms for each regime with limiting long-standing illness. And then we also added cross-level interaction terms for regime and education, using the tertiary education as reference category. So there's one for secondary and one for primary education. And this way, we think we can assess the level of inequalities in the society without losing the employment level, so to speak. But we will look at both. And then we estimated predicted probabilities to obtain the levels and the absolute and relative sickness inequalities. And to make things simple now, I think I will focus my presentation on the difference between the Scandinavian and the Anglo-Saxon regime, because these regimes represent contrasting cases suitable to test the welfare resources perspective towards the disincentive or welfare skepticism perspective. And also I will focus on those who have primary education, because this group is the group that is most likely to respond to these contextual differences. So here's a graph for you, and it shows the predicted probabilities of non-employment among men with limiting long-standing illness within different welfare regimes. So, and the blue bars represent those with primary education. And as you can see from the graph, the sickness level among primary education group is lowest in the Scandinavian regime to the left, and it's higher in the Anglo-Saxon regime in the middle. And also you can see there are different levels of sickness between educational groups in each regime. Now, decomposing these predicted probabilities into our three components with welfare state regimes in the regression analysis revealed this picture, and it's a bit complex actually, because we can see that the predicted probabilities, they are driven by different components in different regimes. So compared to the Scandinavian regime, the Anglo-Saxon regime difference is primarily related to enlarged inequalities in unemployment between the ill and the healthy, because of the significant and positive interaction between limiting long-standing illness and the Anglo-Saxon regime. Even if the predicted level of sickness is higher in all regimes compared to the Scandinavian, only in the Anglo-Saxon is the relative effect of health on unemployment higher than in the Scandinavian regime. This is a bit confusing, but we will show some graphs to make it easier. First, this is the same graph as the first graph, but for women and not only for men. And as you can see, it's pretty much the same picture with the lowest overall levels of sickness in the Scandinavian regime. And yeah. Now, looking at the different components of the association now for women, shows a much more uniform picture. So in the Anglo-Saxon and across all the other regimes, the findings are not driven by larger inequalities between ill and healthy, but by significantly stronger main effects and larger educational inequalities in non-employment. This finding, it may reflect the fact that women in other regimes than the Scandinavian are more often non-employed because of reasons not related to health. Because in Scandinavian we have a generally high level of employment among women. And now looking at the level of inequalities, and there's two ways to look at that. One is the absolute level, and that's just the probability of those with tertiary education, and you subtract the probability of those with low education. And we do this among the people reporting limiting long-standing illness. That's the blue bars. And as we can see, for women in the upper left corner, the Scandinavian regime clearly has the lowest absolute social inequalities in sickness, while the Anglo-Saxon regime has an intermediate position. And in men, in the bottom right corner, the picture is not so clear, but still the Anglo-Saxon regime has significantly higher social inequalities. And then looking at the relative inequalities, which is basically the odds ratios for the educational differences. Again, limiting long-standing illness represented by the blue bars. And now looking at women in the upper left corner again, still the Scandinavian regime has the lowest educational inequalities in sickness. And for men, the picture is, again, not so clear as we would expect. And the sickness, relative inequalities in sickness are not greater in the Anglo-Saxon regime compared to the Scandinavian among men, is what we can conclude from this. So to the overall conclusions, the lowest level of sickness were found within the Scandinavian regime, and particularly among those with low education. And the smallest absolute and relative social inequalities were found among women in the Scandinavian regime, but not among men. So this study does not support a welfare skepticism view on the relationship between welfare regimes and sickness. So, thank you very much. I just want to mention these references. The middle one is now available online. And that's the one looking at the specific welfare arrangements, like generosity and active labor market policies. So you can read more about it there. Thank you.
Thank you very much, Shortell. We have time for just one question. Yes, please. Do we have a microphone?
When you're controlling for limiting long-standing illness, aren't you introducing a artificial association? Because to me, limiting long-standing illness is also a measure of sickness. So you're correlating sickness with sickness, because the limitation in long-standing illness could be the perceived limitation because I have to go on sickness leave or sickness absence. So some of the differences you are showing between limiting and non-limiting illness are artificial because you are correlating two more or less identical measures.
Yeah, yes, you could argue that there's a bit of a tautology there. So, in the limiting long-standing illness question, there's not a question of whether you are not employed because of your health. It's because of how health limits your daily activities or so. So, and having that kind of limitations will vary across countries with working life arrangements. Some places they are good at, adapting workspaces for people with illnesses, and other societies they are not as good. And also, I don't think that I don't know if the tautological part of that measure, if that will vary much across countries, because if it doesn't, I think the cross-country differences will still be interesting or valid, so to speak. Yeah.
Yes, thank you very much. We will go on. Morten Støver, your presentation, I think the topic is unemployment.
It's not about sickness absence.
No. Please.
Can I just use this? Yeah. So the title has changed a bit since I submitted the abstract. It's now called Unemployment and Disability Pension an 18-year follow-up study of a 40-year-old population in a Norwegian county. And our aims with this study was two things: to explore whether unemployment meant an increased risk for later disability pension, and if health, sex, education, age and location of residence had an influence on that risk. So numerous studies have shown that there is an association between unemployment and poor health. And they also show that unemployment and organizational downsizing have been associated with subsequent disability pension. Economic recession tends to affect disadvantaged people more than others and increase the numbers of people who receive disability pension. So, central question is, does employment itself lead to poor health? Or are people with poor health more vulnerable to labor market fluctuations? Research done on this question shows mixed results, but both indicates that work disability does not arise from poor health alone, but from the combination of poor employment opportunities and health impairments. And we argue that the recent European economic recession should mean more attention to prevent inflows from unemployment into disability pension. So, some reports in Norway about big geographical variations in disability pension, but this is most often done without considering the fact that populations at risk can be quite different in different areas. In Scandinavia, there has been done just a few studies within a multi-level analytical framework, but research has shown that there can be geographical differences related to level of urbanization, where people in less urbanized areas have a higher risk of disability pension, and municipality and county deprivation, where people in the most deprived counties or areas are at high risk, and also geographical differences related to practice of rejection of applicants. So we have a data from Nordland County, which is a county situated in the north of Norway. It has 45 municipalities, 235,000 approximately inhabitants. And the data we use are from a national health screening done by people from 40 to 42 years old, and it was done in 1988 and 1989. And we believe that Nordland is a good county to do such a study on because it has a industrial diversity where some municipalities are dominated by fishing, some by farming, some by manufacturing, and some by service industries. And we believe that the different municipalities has been differently affected by business fluctuations through the follow-up. So about 10,500 40 to 42-year-old was invited to this health screening, and about 8,600 showed up. Our follow-up time is from 1992 to 2007, and we believe that the impact of unemployment had some induction time, and we measured risk of disability 1 year after unemployment. Our dependent variable is first date of disability pension, and for most people this means the first day of a long-term sick leave that ends up with a disability pension. We had information about the baseline health, and we used this to adjust for health impairments prior to unemployment. As you can see, self-related health, chronic illness, depression, headache, and pains in neck and shoulder. And we also had information about alcohol use, smoking, and education. So, the association between unemployment and disability pension is estimated with a multi-level logistic regression analysis with individuals nested by municipality of residence. And we estimated an intra-class correlation coefficient, which is an estimate of how much the variance that can be attributed to the second level, in this case the municipality level. So These are the results, and the most important numbers are in bold. No, I forgot to say one thing. We also did test for different time lags, and we did also test for interaction between unemployment and sex education and age. So, the results. We see that unemployment in Model 1 means a higher odds ratio for disability pension the following year. But when we adjust for baseline health, and Model 2 also includes alcohol and smoking, and in Model 3 also includes education, and we see that the estimate is reduced considerably. As you can see also, when we did test with unemployment and 2-year time lag and no time lag, we sort of get the same pattern, but the association is not as strong. And you can see that the interclass correlation coefficient is stable 2% in all models. So, we measured for interaction between unemployment, sex, age, and education, but we found no statistical evidence that neither sex, age, or education affected the relationship between unemployment and disability pension. So, our conclusions. Association between unemployment and disability pension, but when we adjusted for health, lifestyle, and education, this reduced the estimate considerably. And this means that these factors can be common cause for both unemployment and disability pension. We also believe that if we had a better measure for social economy than just education, this might also have reduced the estimate even further. A minor but significant risk of disability pension can be attributed to municipality characteristics, and we found no statistical interaction with unemployment and sex, education, and age. And also important to mention that this study says something about becoming unemployed. It doesn't say anything about the effects of being long-term unemployed. So, picture from Nordland.
Thank you very much, Morten. We have time for several questions, I think. Yes. Well, then I have a question for you.
Okay.
Now we are at a conference for public health, and now we are going to plan what to do. What would you say for the politicians?
What would I
say to the politicians?
No, I don't know what to say to the politicians.
Do you think this is how do you explain your results? Is it you have?
Well, I think that when you see in the media and some reports about these big geographical variations, some of the politicians are using this in a kind of an unfair way, because populations at different places have different backgrounds, and they are different, both in level of education, and you have people with poorer health, people where, especially in the north, where people, the young and healthy people are moving away to find jobs, and the people who still stays there are poorly educated, with poor health, and of course there will be more people with disability pensions in certain areas. So don't misuse our research or something.
Do you think there's some possibilities to prevent your findings?
To prevent?
Yeah, to prevent you find an association here, and you have make some you have taken relevant factors.
I think that
other
I think that people in the employment offices should be aware that for certain people, becoming unemployed can be a big risk factor. So that, I don't know, they follow up them in a good way, I think.
Yes.
Yeah.
Okay. Yes. Any further questions? Thank you very much, Morten.
Thank you.
And the next presentation, I think we get knowledge about the influence of self-reported health behavior and disease on sickness absence. Yes? Anu Holvinen from Helsinki, please.
Okay, thank you. My name is Anu Polvinen and I'm working in Finnish Center for Pensions. And this study is part of my study which concerns socioeconomic differences in disability retirement. Today I present a part study which subject is socioeconomic differences in disability retirement in Finland, the contribution of health behavior and working conditions. Co-writers in this study are Ryan Gold from Finnish Center for Pensions, Eero Lahelma from Hjalti Institute, Department of Public Health, University of Helsinki, and Pekka Martikainen from Population Research Unit, Department of Social Research, University of Helsinki, Finland. And background. In Finland, 7.5% of working age population receives disability pension. This number is a little bit higher than in OECD countries as usual. The main causes for disability are musculoskeletal diseases, mental diseases, mental disorders, and cardiovascular diseases. In younger age groups, the main cause for disability retirement are mental disorders. Average age of disability retirement was 52 years in 2010. We know that employees with low socioeconomic status have higher risk of disability retirement compared to those with higher socioeconomic status. Self-reported health, diseases, obesity, sick leave days, and working conditions are strong predictors of disability retirement. The new studies have found that the association between socioeconomic status and disability retirement is largely mediated through health factors and work-related factors. Recent study from Finland and Norway discuss how health factors, health behavior, and working conditions mediate the socioeconomic differences in disability retirement. Association between social class and disability retirement has found also been weaker in mental disorders than in musculoskeletal diseases. The aim of the study is to examine whether the association between socioeconomic status and disability retirement is mediated through diseases, self-reported health behaviors, and working conditions. Variables are used here. Diseases are circulatory, respiratory, musculoskeletal, other somatic diseases, and mental disorders. Self-reported health is measured by self-reported health, long-term illnesses, sleeping problems, and self-reported anxiety. Health behaviors are smoking, alcohol consumption, obesity, and physical activity. And working conditions are job control, job demand, job support, physical working conditions, chemical and physical risks at work. And these associations are examined on disability retirement due to musculoskeletal diseases and all causes. Compared to earlier studies, we are emphasizing diseases and health factors. And we have three socioeconomic groups. These are blue-collar workers, lower level employees, white collar employees, and self-employed persons we have left out analysis. Data source is nationally representative Health 2000 survey, which register-based retirement data have been linked. Data includes about 10,000 persons aged 18 and over and living in Finland. Home visit interview and health examination were done between August 2000 and May 2001. Health 2000 survey is highly representative study. Almost 89% of the people in the final sample attended the interview and almost 85% took part in health examination. Register data were linked to the Health 2000 with special identification number. And 3,600 persons aged 30 to 62 were employed at the time of the study, and almost 400 persons were retired on disability pension during the follow-up 2000 to 2009. And we used Koch regression model. Here we see the number of study population by socioeconomic status. And second row we have number of disability retirement by socioeconomic groups. And here we can see the hazard ratio of disability retirement do all causes by socioeconomic groups. And we see that blue-collar workers have 2.4 times higher risk of disability retirement compared to white-collar employees do all causes. And in last two rows, we have a number of disability retirement due to musculoskeletal diseases and hazard ratios. And we see that blue-collar workers have 4.5 times higher risk of disability retirement due to musculoskeletal diseases than white-collar employees. And here we have diseases contribution to disability retirement, and we have marked here statistically significant predictors of disability retirement with a star. We can see that especially musculoskeletal diseases and mental disorders and sick leave days predict disability retirement. Only respiratory diseases are not statistically significant. And here we have self-reported health and its contribution to disability retirement. We see that self-reported illnesses, health, self-reported sleeping problems, and self-reported anxiety are all statistically significant. Factors of health behavior like physical exercise, smoking, alcohol consumption, and high obesity are all predictors of disability retirement. Also, I have no picture, but working conditions like job control, job demands, job support, physical working conditions, and chemical and physical risk at work are statistically significant predictors of disability retirement. And here we have the socioeconomic differences in disability retirement among men. And base model here represents age-adjusted hazard ratio for disability retirement to all causes. And here we see that blue-collar workers have almost 2.5 times higher risk of disability pension than white-collar employees. And second model includes also illnesses and sick leave days plus base model. We see that then the risk is almost 2. And third model includes self-reported health and base model. And then is the model health behavior and a model for working conditions. And then we have all these factors together. And we see that working conditions contribution to socioeconomic differences are biggest and health behavior was modest. And when we hold all factors in the same model, we see that socioeconomic differences were almost diminished. And here we have the same analysis for women, and we see that results are quite similar for men. Results are quite similar for women than men, except health behaviors. There exists hardly no effect at all. And then conclusions. We see that risk of disability pension is higher among blue-collar workers than lower-level and upper-level white-collar employees. Large part of the association between socioeconomic status and disability retirement is mediated through diseases, self-reported health behavior, and working conditions. And we see that working conditions effect was most powerful. To reduce the number of disability retirements, we must improve health and working conditions in all socioeconomic groups, but especially in lower socioeconomic groups. Thank you.
Thank you, Anu. And the audience questions? No? Well, then we'll go on. Thank you very much.
Thank you.
The next presentation is Christina Pappe from Trondheim, Norway. Please, Christina.
Okay, hi. My name is Christina Pappe. I am from the University of Trondheim. And today I will present this abstract, which is from a new study that has not been finished. And these results are preliminary and they have not been published. The title is, as you can see, long. Medical welfare dependence within families, a cohort study of health, socioeconomic status, and work disability in young people and their parents. So a short background, both in Norway and also in many European and other countries, there has been a rising concern for young people dropping out from school and from work. And this is a large problem for the young people themselves, but also a problem to the societies in many ways. And one of the problems is that they cost money. And in Norway and other Scandinavian countries, many of these people end up receiving medical benefits. In other countries, they might end up with unemployment benefits also, or no money at all. We believe that when assessing the vulnerability of young people, it is important to remember that young people are a part of a family and to regard them in that context. And this is maybe obvious, but there are several reasons why we should do that. And parents and children, they in most cases, they share the genes, and they also share the same environment. And through the genes and the environment, we know that many factors are transferred from parents to the children. For example, socioeconomic status, many diseases, risk behavior, teenage pregnancy, a lot of things. And we believe that also benefit reception or welfare dependency might be transferred between generations. And although this might be an obvious thing, there has not been very much research on this topic, and clinical practice has not focused too much on family factors either. So this is our main study question. Did young people more often receive medical benefits if they as adolescents had parents who received medical benefits? And in order to receive these medical benefits, you have to have a health problem. And in that way, health is an important factor. Health is also often shared in the family between parents and children. And this was one of our other aims, to explore the role of health, and mainly then as a confounder. In addition, we know that there are strong socioeconomic gradients in benefit reception and also in health. And we wonder if there was also social gradients in the relationships which I have already mentioned. And in order to answer these questions, we have used data from the Hunt studies. This is a large population study from the middle of Norway. And in the mid-90s, almost 9,000 adolescents, they answered a questionnaire. And this Young Hunt cohort, this is our main study cohort. And thanks to the good Norwegian registers, we can follow all these young people for 10 years in the Social Insurance Administration registers. And we also have information on their parents, most of their parents. Between 60 and 80% of their parents, they participated in the Hunt 2 studies, done at the same time as the Young Hunt. And we have information on variables from the parents. And for the parents, we also have information from the National Insurance Administration registers from the time around the Hunt studies. Our main outcome is medical benefits that are received by the young people in the follow-up time. And we only included long-term benefits that were received more than 100 days per year. And in the Norwegian system, this comprises sickness benefits, rehabilitation benefits, and also disability benefits. And the main exposure were medical benefits received by the parents in the years before the follow-up period, and with the same criteria. We collected information on health from the Young Hunt and the Hunt studies. And we assessed socioeconomic status by parental educational level. So I will present some descriptive statistics. Is there a red thing? Mm-hmm. Okay. Here you can see parents and no benefits and benefits. And here you see the adolescents with no benefits and benefits. And in the follow-up period, 1,036 of the adolescents received a benefit at some point of time. And that represented 12% of the total cohort. And almost 24% of the cohort had parents who received benefits. And you can see in the group of adolescents with parents without benefits, 10% of the adolescents later received benefits, while in the group with parents on benefits, 18% later received benefits. And we can see the same thing in this more longitudinal graph. Here at the x-axis, you can see the age of the young people during follow-up. And on the y-axis, you see the percent receiving benefit. And the dashed black line are those with parents without benefits, and the red line are those with parents on benefits. And we can see here that almost twice as many adolescents received benefits if the parents received benefits. And that is at all ages, and it seems also to continue beyond this graph. And these are all descriptives. In order to examine this relationship more properly, we have also done multivariable regression modeling. And I will present some of the results here. Here we compare the two groups of adolescents, the adolescents with parents who received benefits with the adolescents with parents who did not receive benefits. And you can see the results presented with a relative measure between the groups as an odds ratio. And in order to have a better picture of what this represents in practice, we have also predicted 10-year risks in the two groups of receiving a benefit. And in this first model, it's a crude model adjusted for age and follow-up time and sex. And you can see that the adolescents with parents on benefits, they had an odds ratio of 2.12 compared to the other group. And if you see at the predicted risks, they had 11.3 and almost 20% 10-year risk of benefit reception. In the second model, we have included health. And in order to include health, we have made a health propensity score comprising a wide range of health variables from both parents and adolescents. And adjusting for health, it, as you see, diminishes the estimates somewhat, but they are still important. And when including parental education in addition, you can see the same thing, that the results are somewhat lowered, but they are still important. These results are with both sexes. We know that there are differences between boys and girls, and I will show you both separate analysis for boys and girls and also analysis according to socioeconomic status of the parents. The odds ratios here, it represents the effect of having or the relative difference between having parents on benefits with those with parents without benefits. And you can see that the differences are a larger bit for girls. And especially when you look at the absolute differences here as a risk difference. And here, according to parental education, we see that the odds ratios for those having parents on benefits in almost all groups, it's almost the same, but there's one group who stands out, and that is a group with parents with the lowest level of education. It's only primary education. And they have a 16.6 risk increase in the 10-year risk. Oops. So, to conclude, we have seen that adolescents with parents receiving medical benefits, they had 80 to 100% increased odds of benefit reception in early adulthood. And we have also seen that health only seems to account for a small part of this association. And we have, I'm sorry, but this is wrong. But we have also seen that there are social gradients in this relationship. So, thank you.
Do we have some questions? No? Could you tell a little bit about your next step?
My next step?
Yes.
In what?
Yeah.
In the analysis?
Yes,
Or
yes,
in... In what way?
Okay. But you have done these findings. What would you do next? If you could?
If I could?
Yes.
In practice or in
No,
science?
Yes, in science.
No, this is just like a taste of the results, and there are many. It's a very complex area, and there are so many things working together, and it's difficult to tell the whole story here.
Yeah.
But this is a part of an article which will reflect more of these issues.
Okay.
So
that's fine. Thank you. Yeah. Oh, one question. Please, could you present yourself? We have some sound problems. Yes.
Okay, I was just wondering what role will income play in these associations? Differences in income?
I am not sure. We in this study and also in our other studies, we have mainly focused on parental education as a measure of socioeconomic status, and that is based on prior research mainly. That for this group of it's a young cohort, and the parents are also young, and for this group, we believe that the parental education is a better measure, but you could also include income, but I don't think it will matter, but we can also look at that.
Okay. Thank you very much, Christina. And now we will take the last presentation, Else Nygaard from Copenhagen, Job Mobility and Disease. Please.
Good afternoon. This is a group who's working on these labor market questions, and specifically on the question of job mobility and health. And the group comprises Carsten Thielen, Charlotte Hovgaard, Astrid Lidegaard, Finn Didriksen, and myself. And we are from the section of Social Medicine, Department of Public Health Sciences. The point of departure for us to initiate the study has been the flexicurity model with the main cornerstones of a flexible workforce, which is the flexibility part of the model, and a relatively high compensation during unemployment, the security part of the model, as illustrated by Per Kongshøj Madsen in this figure. Among various forms of flexibility, functional, economic, temporal, and numerical flexibility, the latter allows for the ease with which employers can recruit and get rid of employees, which has given Denmark a leading position in that job mobility of the Danish labor force ranks the highest among OECD countries. Job mobility in our study comprises all kinds of mobility of the labor force, meaning mobility in and out of jobs, between jobs, and between job and unemployment, etc. Job mobility may open up for new possibilities in terms of improving the fit between man and machine and job demands. The other side of the coin could be increased social stress and adverse health effects. Thus, the aim of the study was to analyze the effect of job mobility upon selected diseases: ischemic heart disease, cardiovascular disease of the brain, gastric ulcer, cancer of the lungs and of colon, alcohol-related diseases, and depression. We used a register-based cohort design. Starting point is year 2002. The study population was identified in the Central Person Registry of Statistics Denmark and consisted of all 40 to 50 years old men and women, all active on the labor market. Persons were excluded who, during 1997 to 2001, had been registered in the National Patient Registry with a disease on the study, and persons who had received disablement pension and who were no longer active on the labor market. Job mobility, the exposure variable, was registered annually during a 10-year period from 1992 to 2001 and grouped into 4 categories: zero mobility, 1 to 4 times mobility, 5 to 9 times mobility, and 10 times mobility during this 10 years period. Data on job mobility came from Statistics Denmark from the Integrated Labour Market Database. The health outcomes of selected diseases, for instance, ischemic heart disease, was registered during a 5-year follow-up period from 2002 to 2006. Data on health outcome came from the National Patient Registry. The number of persons included for the analysis of ischemic heart disease amounted to 749,617, nearly 750,000, as shown there. For the Integrated Labour Market Database registrations, registrations are made once a year in November. Therefore, and for other reasons, the specification of job mobility may be underestimated. Diseases defined according to International Classification of Diseases, version 10 in the National Patient Registry, and includes these diseases which I have already mentioned. Confounders. As confounders, we included sex, age, education, unemployment, and ethnicity based upon country of origin. Analysis were stratified for sex, and age was entered as a continuous variable. Ethnicity comprises 4 categories of country of origin, namely Denmark, Europe and Western world, Third World and the Balkans, and unknown. Education is registered according to the International Standard Classification of Education into 4 categories, and unemployment is summed up through annual degree of unemployment during the period 1992 to 2001 into 3 categories: 0 unemployment, less than 12 months, and more than 12 months. We use logistic regression models to calculate the effect of job mobility on the risk of disease during follow-up by odds ratios and confidence intervals. This slide shows results from the analysis of the health outcome of ischemic heart disease. Altogether, these 750,000 subjects were included, which is shown down there. During a 10-year period, 13 to 14% of the study group were job mobile 10 times or more, as shown there. The distributions on mobility, education, unemployment, and country of origin all show a graduated relationship to ischemic heart disease. For instance, 1.6% males had zero mobility were registered with ischemic heart disease as compared to 2.2% of persons with maximum mobility. 1.6 and 2.2. Same picture is seen in women to the right. And for each of the confounder variables as well: low education, a high proportion of ischemic heart disease. There. A high degree of unemployment, more than 12 months, in parallel with a high proportion of ischemic heart disease. And coming from Third World and the Balkans is seen with a higher proportion of ischemic heart disease than being born in Denmark. This slide shows the unadjusted and the fully adjusted odds ratios of job mobility upon ischemic heart disease. Men to the left and women to the right. In both men and women, a significant effect is seen of highest job mobility upon ischemic heart disease. In men and in women. This slide shows odds ratios for highest level of job mobility upon selected diseases from fully adjusted models. Ischemic heart disease has been commented upon. Alcohol-related diseases shows the highest odds ratio, and next comes depression in both men and women. Alcohol-related disease 2.4 and 3.5 in male and female, and depression 1.6 and 1.7 in women. In conclusion, we have demonstrated that job mobility during a 10-year period has an independent graduated effect upon a broad spectrum of diseases during 5 years of follow-up. The highest risks were seen in relation to alcohol-related diseases and to depression in both men and women. Exceptions from this picture were cancer colon and cancer of the lungs in men. Next steps. Our next step will be to turn the arrow and to study the effect of selected diseases upon job mobility. And also we will study in more detail questions related to voluntary or involuntary job mobility. Meanwhile, the latest labour market reform has brought about changes to the flexicurity model through a reduction of the period for compensation during unemployment. It's been reduced from 4 to 2 years, and through a reduction of educational activities during unemployment, which was the third cornerstone of the flexicurity model. But with the recent change of government, new life may be given to the flexicurity model. Thank you for your attention.
Thank you very much, Else. Any questions? In the start of your presentation, you said that there could be some different explanations, or flexicurity could have positive or negative consequences, and you mentioned stress. Do you think stress can explain your findings? Or
well,
could you think of
we have
other explanations?
The selection of diseases that we have studied also expresses diseases where stress may play a role. And now it's not the flexicurity model itself that we have studied, it's the only one cornerstone, the job mobility. And being fired might introduce some stress in your total life situation and may be the cause of, disease. But at the same time, if job mobility is voluntary, it's your own choice. It may be one step in a career. It may have positive effects and not affect your health. This was what I meant to allude to. Mm.
Yeah.
No, it's not. Okay. I was wondering whether, did you control for initial health in your models? Because if you didn't...
Initial health?
Yeah, the health status before the follow.
We only to the degree that we excluded persons from the analysis who 5 years prior to base year had been registered in the patient registry with the disease under study.
Okay.
So this is part of a yes to
so
your question.
Health would have should have been quite severe.
Yes.
To be recorded.
Sure,
Yeah.
sure.
So the findings really then could reflect the health of the people that had kind of minor health problems, and during the time they got larger, and then they were forced to be mobile.
Yes,
in a way, maybe.
Yes,
yeah.
That's true, and this is a reason why we want to turn the arrow around and look at it from this perspective. Mm.
Thank you.
Thank you.
Thank you. Yes. Thank you, Else. Oh, was one question more? Okay. I'm sorry, Jens. We take one more, Else. It's okay.
Just one more. Do you think your exposure time is long enough to reflect, to be reflected in the diseases you had to do with?
Exposure time of yes, yes, I think so, because it's the number of events during the 10 years. So that's the idea, that the exposure time should be enough to have an effect.
So you think 5 to 10 years of mobility would reflect...
10 years.
10 years would reflect in cardiovascular diseases or colon cancer and so on?
Not to the degree that it would cause the disease, but it might worsen. This is actually binding up to the question that Kjetil asked. But you don't agree on that point, or you disagree? Yes.
Yes, in the coffee
All
break
right.
you can have a discussion. Okay, thank you very much. I think we have had, yes, I think we have had 5 excellent presentations, and I think we have to applause our presenters. Thank you very much. Now I think it's coffee break, or yeah, please drink some coffee, and thank you very much for coming here.